So you find the clavicle, you come around, and where the clavicle becomes most concave, where it moves most posteriorly, so here's clavicle, clavicle, and then come right under that, that's the coracoid process right there. Okay, so what attaches to the coracoid process? Pec minor. The biceps. Biceps, right, okay. If you want to follow the clavicle, go past that concave point, keep coming, that's when it's going to hit the acromion, and this is your AC joint right here. So if you've had a separation, that's where they're going to feel, you may feel the clavicle tipping up a little bit or being tilted up, and that would be like a grade 2, 3 separation. Greater tuberosity, what attaches to that?
Most of the rotators.
Most of your rotator cuff muscles. You can't palpate it until she goes back. She's got to go into some medial rotation, extension, and adduction. You find the most anterior aspect of the acromion process. So here's my most anterior aspect of the acromion. Now bring your arm behind your back. Okay? If I move down, that's the greater tuberosity right there. If I move up a little bit, that's the supraspinatus tendon right there. Biceps tendon, the long head, we're basically just, what I do is I just kind of wiggle back and forth, and I'm right in that bicipital groove. You know you're on it if you can feel it kind of snapping back and forth. So right in here is where that bicipital groove is. It's lateral to that coracoid process. So if you have no painful arc, but you have pain on resisted abduction, it might be coming from the supraspinatus muscle itself. But I want to get everything on slack here. So I'll bring her way up. So you find the spine of the scapula, okay? So you guys should be able to find the spine of your scapula, and right between, right above the spine of the scapula is where that supraspinatus muscle belly lies. And what the patient do, I'll show on this side. Put your arm down, palm down, grab the edge of the table. So she's in a little bit of external rotation. Now I would normally be standing over there, but I'm doing this for the camera. I have her kind of shift her weight a little bit, all right? This is how we're going to access the tendon, but I can show you where we're going to access that muscle too. You know where the spine of the scapula is, so you have to find that spine of the scapula. So just follow along the spine of the scapula, and then below that, and this is where if you guys have Jeff, there you go. A lot of trigger points in this area, okay? So you can follow that muscle belly out, okay? And then right around in here is where we're going to start to feel that, scoot you a little, there we go. We'll be able to feel that tendon, okay? Now if you have a tendinitis and she doesn't, you'll feel it. It is thick. Now,
raise your arm to 90 degrees into the scapular plane, okay? So again, here's straight abduction. I go 30 degrees off of that. And then I'm forcefully going to internally rotate her, okay? What I'm looking for is for her to say, ow, that hurts. And when she says, ow, that hurts, I ask, and they typically tend to say right up and through the shoulder. Is I am going to passively, okay, I tell her you just relax, and I passively flex her arm to her end of the range, okay? And what she will say, if it is positive, just like that. Can you do that again? It points right to it. She's going to have pain in that subacromial space, okay? And then back down. It's a passive test, and you're looking for pain. So I bring her up here. Okay, inscaption at about 45 degrees, and I say, don't let me move you. Okay. Don't let me move you. Hold that. Does that hurt? Nope. She says no. I bring her up higher to 90. Okay, don't let me move you. Oh, she says that hurts, or it's weak, or whatever. All right, and it's up at 90, so it would be what? Percent. Here, what you got to do is you got to make sure, okay, that we find the biceps right there. right there. All right? And then we are going to supinate our arm. Raise it to 90. Okay, keep your elbow straight. Okay. And I'm going to... You okay?
Yeah, no, just wondering how strong I'll be.
I don't care how strong you are, really. All right. So now I'm going to say, ready? We're going to say, don't let me move you. Okay? Don't let me move you. Don't let me move you. And relax. Did that hurt?
No.
Bring her all the way back. Okay? Keep palpating here. And then I say, don't let me move you. Ready?
Okay.
Don't let me move you. Don't let me move you. Okay? And we ask if that hurts. And if it hurts, it's positive, obviously, for bicipital tendonitis, because I'm asking the biceps muscle to contract. Now here, you're supposed, in this position, you're resisting both shoulder flexion and elbow flexion.
So all we're really doing is we ask our patient to bring your arms out in front of you, thumbs down, a little bit adducted, so like about 20 degrees in front of her. And all I'm doing is I'm just applying resistance. And I do this bilaterally. So if this is injured, non-injured, I would do them at the same time. And I just say, hold strong. Hold, 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 hold. Okay? If it's positive, one arm is going to be a lot weaker. However, then what you do is you do this. And technically the test is then repeated, like with the arms externally rotated. Hold, 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 hold. All right. If she had a labral tear, she would be strong here, but not strong here.
Is you're going to abduct her arm to 90. You're going to slowly externally rotate her shoulder. You look at her face, okay? And if she's like, ooh, right, she won't do this, okay? Or else, here's the other thing. What happens if she guards on you?
That's apprehension.
Okay, that's positive. You know, it's technically not positive, but you want to stop, okay? Because you don't want to try to force it through her thing, because then she's definitely going to pop out on you, okay? So again, you're looking at after an apprehensive kind of reaction from her, or she'll just say, no, don't go there. So again, you're here, and she gives you this grimace or this "don't go there," you know, type of thing. But hopefully, she doesn't say that, because then you can't do the relocation. And as I'm externally rotating her, I'm giving her a posterior force, okay? And what am I doing to her humeral head?
Pushing it back.
Yeah, I'm relocating it back into the fossa, and then I externally rotate her. And I do not allow that humeral head to translate anteriorly. I'm sorry. Okay? And then what should happen? Should this be painful anymore?
Really not.
No.
Their arm is up like so. I get my hand behind the humeral head, and all I'm doing is I'm just pushing straight down. Now, if she starts to freak out a little bit about that, that's a sign of posterior apprehension. All I'm really doing here is it's essentially like a posterior glide. So I've got my hand on the scapula, relax your arm. I've got her passively up to 90. I push straight posteriorly, so I'm stabilizing the scapula, so the humerus is moving on the scapula. So I push posteriorly, and then what I'm going to do is I go across while I am maintaining that force. So I'm not pushing, my hand is going that way. I'm always directing my force through the humerus. All right, so as I'm coming here, the force is going this way. And a clunk or a jerk, you'll feel it. It'll be like a, it'll it's not a nice feeling. A little click is not a positive test. It's a jerk or like a clunk with that. But you're palpating, you pull down. Ooh.
Yeah.
Okay? So that's an example of a positive sulcus sign. All right? What I do here is I just palpate his pulse. Boom, boom, boom. So I've got the pulse. I bring his arm back, and I have him turn his head to the right. So the absence test is really looking at the scalenes, okay? He turns his head this way, and I look to see if there is any change in the pulse. If it's positive, the pulse is going to get really, really quiet. Turn your head the other way now. And it's fine. So he has a negative absence test. is again, I'm palpating his pulse again. And I bring his arm back and I just say, squeeze your shoulder blades for me. And now we're getting a little,
I can feel it in my
you can
hand.
feel his hand is starting to get symptoms. He's starting to get some blue. The pulse is diminishing. Okay, so he's getting some compression through here. Yep, now it's really starting to dilate. So again, palpating, and then I just bring his arm all the way up. Yep. And it's gone. Pulse is gone. Bring your arms back. So it's open and close, open and close. Just keep doing it. Okay, keep doing it.
He's going.
Keep doing it. Keep doing it. 3 minutes. 3 minutes. And if he started to get white here, I mean, you're starting to sweat. Yeah, you can stop now. Some of those tests might be positive. Some of those tests might be negative. People that have thoracic outlet syndrome, again, it could be a vascular issue or it could be a neurological issue. And it's often, if it's neurological, it's aggravated by adverse neural tension. So on these patients, just getting a lot of flexibility back for them is really, really helpful.